All right, let's get right into it. Prostate cancer. It's a topic that you hear about all the time. It affects millions of men, their partners, their families. But honestly, it's surrounded by so much confusion and, frankly, a lot of fear. What are the real risks? What do all those tests actually mean? Well, today we're going to break it all down. We're going to demystify it, using the clinical facts to give you a clear picture of what you really need to know.
So, to kick things off, let's get a sense of just how big this issue is. I want you to think about this question for a second. If you take skin cancer out of the equation, what is the single most common cancer that affects American men? The answer really sets the stage for everything we're about to cover.
Yep, it's prostate cancer. We're talking more than 174,000 new cases diagnosed in the United States every single year. That is a staggering number. It means this isn't some rare thing. It's a major public health conversation. But, and this is a huge but, here's where it gets really complicated. This quote gets right to the heart of the matter. The evidence is crystal clear. Even though so many men are diagnosed with prostate cancer, most of them will end up dying from something totally different, like heart disease or a stroke. And that creates this incredible dilemma for doctors and patients.
Which brings us to what's known as the prostate cancer paradox. The real puzzle here is trying to figure out which cancers are the aggressive, life-threatening ones that need to be treated, and which ones are the slow-growing, sleepy kind of cancers that might never actually cause any harm. It's this high-stakes balancing act between catching the bad ones and not over-treating the harmless ones. To really get this paradox, you got to look at the prostate itself. Think of it like a city with different neighborhoods or zones. As you can see here, the common non-cancerous growth, that's BPH or benign prostate enlargement, it usually happens in the inner transition zone. But most cancers, which are labeled here as CAP, they tend to start in the outer peripheral zone. This is so important because it explains why urinary symptoms, which come from that inner zone getting squeezed, often have absolutely nothing to do with cancer in that outer zone. So, if it's this common, the big question is, who is most at risk? Let's break down the key factors that really increase a man's chances of developing this disease.
The science really points to four big ones. First and foremost, the single biggest risk factor is just getting older. The data also shows that African American men have a significantly higher risk, and the cancer often appears at a younger age. A strong family history is another huge one, especially if your father or brother had it. And finally, there's a clear link to the typical Western diet, specifically one that's high in animal fats. And just look at this chart. It really paints a picture of that age risk. For a guy in his 40s or 50s, the chance of being diagnosed is around 1 in 100. But then look at that jump. Between the ages of 60 and 79, that risk skyrockets to 1 in 8. It's a massive increase. And it's why those screening conversations usually get serious around age 50.
Okay, let me clear something up right now, because this is probably one of the biggest misconceptions out there. Having an enlarged prostate, that BPH we talked about, does not, I repeat, does not increase your risk of getting prostate cancer. Yes, they can happen at the same time, and yes, BPH can make your PSA level go up, but one does not cause the other. There are two separate issues, often happening in two different parts of the prostate. All right, now for the big one. The part of this story that's probably the most well-known and definitely the most controversial, the PSA test. Let's dig into what it is, what it's really telling us, and why there's so much debate around it.
So what is this thing? Prostate-specific antigen, or PSA, is just a protein. And the crucial thing to understand is that it's made by all prostate cells, the healthy ones and the cancerous ones. So a high PSA level does not mean you have cancer. Think of it more like a smoke detector. It's a risk indicator. It's a red flag telling you to look closer, but it is absolutely not a cancer test itself.
And this quote from the medical text just says it all. There is no magic number for PSA, no safe level where the risk is 0. It's a spectrum. A lower number means lower risk. A higher number means higher risk. It's a continuum. And that's exactly why interpreting a PSA result is so tricky.
So what actually happens if your PSA comes back high?
Well, it's not an automatic go get a biopsy situation. It's the start of a conversation. A good doctor is going to look at the whole picture: your age, your race, your family history, how fast the PSA is rising. And then, together, you make a shared decision about what to do next. A biopsy might be the right call, but it's a decision you make together.
Okay, so let's say a biopsy does find cancer. The next question is, honestly, the most important one of all. How aggressive is it? This isn't really about how big the tumor is. It's about its personality.
Is it lazy and slow, or is it angry and fast-moving? The answer to that question comes from something called the Gleason score. It's basically a grading system. A pathologist looks at the cancer cells under a microscope and judges them based on how messed up they look compared to normal, healthy prostate tissue. Now, how they get this score is actually pretty simple math. The pathologist finds the most common cell pattern they see and gives it a grade, usually from 3 to 5. Then they find the second most common pattern and give it a grade. Then you just add those two numbers together, so a 3 plus a 4 gives you a Gleason score of 7. Easy enough, right? And this right here, this is what the pathologist is actually looking at. On the left, you've got a low-grade Gleason 3 pattern. See how the glands are still pretty well formed and organized? They look neat. Now look at the right. That's a high-grade Gleason 5. It's just a chaotic mess of cells with no structure at all. You don't need to be a doctor to see that one of these looks a lot scarier than the other.
You know, that Gleason score can be a little confusing, right? Especially because a Gleason 7 can mean two different things. So to make things way clearer, especially for patients, experts created this new system called grade groups. It's much more intuitive. Grade group 1 is the lowest risk possible, and crucially, it separates a 3 plus 4 equals 7, which is mostly low grade, from a 4 plus 3 equals 7, which is mostly high grade and carries a much more serious prognosis.
Okay, so you've got a diagnosis, you've got a grade, all this information, the PSA, the risk factors, the grade group. It all comes together now to answer that one big question. What do we do? And really, when you boil it all down, there are two main roads you can go down. For those low-risk, grade group 1 cancers, the path is often something called active surveillance. That means you watch it closely, you monitor it, but the goal is to avoid or at least delay treatment and all its side effects. But for the higher-risk cancers, the goal shifts completely to active treatment, things like surgery or radiation, with the clear intent of curing the cancer for good.
And this is why that decision is so important. This is what everyone wants to avoid. This is a bone scan showing a skeleton just riddled with prostate cancer that has spread. This is what an aggressive, high-risk cancer can do if it isn't caught and treated effectively. The whole point of active treatment is to make sure the disease never, ever gets to this stage. But let's bring it all back around to that paradox we talked about at the very beginning. For that huge number of men who are diagnosed with low-risk, low-grade disease, the thinking in medicine has changed dramatically. Treatment is not always the best first step. Today, for those men, active surveillance is the standard, recommended approach designed to protect their quality of life from a treatment they might not even need.
And look, making these huge decisions isn't just a gut feeling. Doctors use incredibly sophisticated tools, like this nomogram here, to help. They plug in all the specific details of a case, the PSA, the Gleason score, the stage, and it spits out a personalized probability of different outcomes. It helps turn a ton of complex data into a much clearer picture to guide that critical conversation about what to do next.
So, after all of this, after breaking down the risks, the tests, and the grades, we end right here with a question. Because at the end of the day, there is no single right answer that fits everyone. The goal of all this information isn't to tell you what to do. The goal is to empower you, to give you the knowledge you need to have a real, informed conversation with your doctor and figure out what the right path is for you.